instability. You see what I'm getting at? Fracture, right? So it's all pain. I keep telling you guys, pain is not a good predictor for anything, right? It's not really good diagnostics for anything. You can have pain associated with things, and things may actually not be painless, but still be out. Does that make sense? And we talked about that when we came to flexor tendon injuries. If it's out, it's not going to hurt in the flexor tendon injury because it's not doing anything. It's out. Does that make sense? You won't have necessarily tendon pain per se. It's just the pain from the incision or the wound itself. So that's just an example. All right. So getting started, meniscal tear. So when we talk about the menisci, right, we have two of them, right? So I have the medial and the lateral meniscus, right? And so you have one on the left side and the right side. Bless you. That's a wet t-shirt. So when we're talking about this, right, how can we tell which side is medial and which side is lateral? Okay? So we talk about the popliteus tendon and how it's in the posterior lateral corner, correct? Bless you, sir. So, popliteal tendon, so that tells us something, right? But which is the largest condyle? Which is the largest meniscus? Okay. We're putting it all together, right? All those things, you're like, why does he keep saying certain things, right? So you can tell where you are when you're going through an axial cut, sagittal cut, etc. of a knee, and be like, I wonder if I'm medial or lateral, right? You can start using your knowledge of anatomy to put these things together. But you would agree that both menisci look like large C's, correct? Yes, sir.
Just to clarify, so medial meniscus is the
Yes. Medial condyle. Yes. Okay. Do you disagree with that? You agree with that, sir? You do? Okay. For now, blindly and trusting, right? Yeah. But it's important to understand that because when you're talking about these things, right, your anatomy becomes relevant as well because if you see the popliteal tendon, is that lateral or medial? It's lateral, correct? So no, again, one reference point is nothing, right? When you're plotting coordinates, you use one reference point or multiple? Multiple reference points, correct? So again, your knowledge of anatomy can be strong. But what does the meniscus do, or the menisci, right? They act as shock absorbers between the femoral condyles and the tibial plateaus. There's that term tibial plateau, right? So we know that's the summit, if you will, the plateau, right? So the top of the tibia, okay? And tears disrupt the normal mechanics of the knee. So basically, when you have a tear of the meniscus, right, it's important to understand if it's lateral or medial. Okay, we're there. And it's the lateral meniscus or medial meniscus. And then is it anterior or posterior? That's one concept that people don't really think about, right? They're like, it's just a medial meniscal tear. But posterior horn medial meniscal tears are the most common. We did talk about meniscal tears, correct? Being common with ACLs. But then what is the most common medial meniscal tear? And it's posterior horn, okay? So we'll talk about the different kinds here in a second. But when you see these reports, right, in your practice, you're going to want to kind of start zeroing in on, okay, is this something I need to refer, or is this something I need to kind of sit with? Send a PT, do a tube modification, etc. So again, they can occur alone, right, isolated, or in concert with an ACL injury. Okay, make sense? All right, we're just going through that again. So these are some pictures that were provided to you. Okay, they basically go through the different kinds. Okay. And I think it's important to understand that when you're talking about meniscal tears in general, right, you're talking about radial, oblique, horizontal, complex, longitudinal. Then there's things like parrot beak, right? Then there's things like bucket handle at the bottom right there. The bucket handle one is one that you, in clinical practices, PCMs, you can't miss those when they present to you with certain exam findings, okay? Because bucket handle tears, while it's not considered to be an emergent situation, or an emergency, excuse me, it is an emergent situation, meaning if somebody has a bucket handle tear, look at that tear there, right, on the bottom right. When you look at that tear there, does it seem like that piece that's torn, it's kind of flapped away, could get stuck in between the condyle and the plateau and cause a mechanical block to motion like we keep discussing? Yes, right? So what will happen is, right, the patient will be able to extend, flex and extend, and all of a sudden they can't. They get stuck in a certain position, right? It's almost like that concept of triggering, correct? Where you get stuck, and they can do certain heroic measures sometimes. Some people do it like as a party trick, okay? They kind of sit there and they say, watch this, I'm gonna lock my knee in, okay, now I'm going to unlock it, right? Marines are weird people, okay? But every time you lock and unlock it, are you causing further propagation of that tear? Yes, right? And if it gets stuck, you cannot unlock it, as we say, right? It's locked in position, and the patient can't do it, and you can't do it on exam. That's something that you need to let us know sooner than later, okay? Because we'll have to go in there, right, and look at that under arthroscopy and repair that, okay? Everything else is all academic in the sense that if it's horizontal, longitudinal, things like that, as long as it's not causing the patient to have locking, catching and locking, we can get to it, right? But again, if they're getting caught and locked, then you have to get to it sooner because will the patient walk around with their knee flexed at 60 degrees? Is that the way they like to walk? That's just weird, right? And that's what ends up happening. Okay, does that make sense? So when it comes to the medial bucket handle tear, excuse me, is that technically a complex tear? Depends on how you look at it. So I would not get too focused on all this longitudinal, horizontal, complex, but the bucket handle is one that you'll see very commonly, not only tested, but in practice, it'll be something you need to be looking for to make sure that the patient doesn't have that. Does that make sense? Okay. And we'll talk about the typical patient presentation here. Okay. So when we talk about clinical symptoms, they do report a twisting injury, so very similar to ACLs, right? Another reason why they can go together, right? But were they able to continue play or not able to continue play? Within a meniscal. All right, so they were able to continue to play, right? That's what the thumbs ups were. Okay, so what if they have an ACL with a meniscal tear? Then it's all very confusing, correct? So this is talking about just isolated meniscal tears in the absence of an ACL tear, just to be clear. Make sense? Okay. So, pain worsens with twisting and squatting activities. You remember how I was just describing to you that not only is there medial and lateral, but depending on the particular meniscus, right? Then there's also anterior and posterior. So do you think that depending on where the tear is, whether it's anterior or posterior, they'll get symptoms and pain in certain ranges of flexion or extension? Yes, the answer is always yes, right? I just get him to start rolling his sleeve up every time. Right? So when we're talking about that, there's a test for that, isn't there? Isn't there a test where we take it to flexion and extension, and we kind of like rotate the foot out and in? Yeah, there's a test for that. Ah, got it. So we just put it together. We just put all our knowledge of anatomy together and decided that we understand why we do a McMurray's test now. Because it's not just trying to decide whether it's lateral or medial, right? So in or out, inside or outside, excuse me. You're also trying to decide whether it's anterior or posterior, potentially. Does that make sense? So if you actually read your textbook, right, what color's the book? Orange. You guys have all sent a spy, right? Somebody bought the book and showed it to everybody, so you know it's orange. But if you read the book, right, and you read other textbooks, it'll tell you that you can actually discern whether it's anterior or posterior too, based on the position that the knee's in when they have the McMurray signs, when they have that pain or that clicking. Does that make sense? You can actually determine it. Good to go? So if you get really good at the McMurrays, not just I did it for the OSCE and I passed, right? Then you can start deciding for yourself whether it's anterior or posterior as well. Okay? So mechanical symptoms, that is the hallmark, if you will. Okay? So mechanical symptoms meaning it's not instability, it's that snap, crackle, pop that I was telling you guys about, right? If you don't remember what questions they ask on your OSCE when you get ortho, think snap, crackle, pop, because you're asking about that in most body parts and trying to discern whether or not the patient has mechanical symptoms or there's bony ends that are rubbing against each other, right? So it'll help you. What's the most common? Anterior horn medial meniscus tear, okay? That is for just isolated meniscal tears. Again, when you start talking about certain pathologies, this is why I tell you don't read too much, because then you start realizing that when it comes to ACL as well, right, if you also have an ACL tear, it may be some other meniscal tear. But just in general, all comers, no other pathology, your book says anterior horn medial meniscus. Okay? So I'll stick to that. Does that make sense? Okay? We gotta stick to something. Okay? So here's your exam. So what are we talking about here? So when we're talking about tenderness, right, it's not just it hurts in and around the knee, it's do they have joint line tenderness? So again, you're going to decide when you're at the joint line. So what's our landmarks there to finding? Excuse me. Say we're trying to find the medial femoral condyle, right? So you're feeling the condyle, then you feel nothing, right? And then you feel the tibial plateau. Is the space in between the joint line? Yes. So you're using your anatomy to find the joint line. Does that make sense? So when you're doing your sparkle fingers, as Colonel Sylvester would say, okay, I say it correctly, please. So when you're doing your sparkle fingers, right, then you that's what you're feeling for. You're trying to feel those anatomic landmarks, find that gap, then find the tibial plateau, and you decide for yourself, there I am. Is that what we also do to find the space to inject? To a corticosteroid inject? Yeah. Right? We use the patella to cheat a little bit too. Right? And we use those same landmarks to find our surgical landmarks when we're drawing on the patient, you know, when they're asleep, or we're trying to decide where we're going to start poking scalpels and putting instruments in. Make sense? So it's the same thing. So we do the same thing. We don't do anything different. We just use our anatomical landmarks. So traumatic tears of the capsule attachment. So that's like another little subset, right? Young patients, they can have effusion, hemarthrosis. How useful is that? Not sure. Do we get MRIs a lot of times for meniscal injuries? Absolutely. Okay? We gotta know what we're getting ourselves into before we get in there. So, incarcerated fragment equals limited passive range of motion. What did I just tell you that kind of tear is? Bucket handle tear. That's all they're telling you there. Right? So that picture was added to put some context to it, right? Allegedly. To make sure you guys understand. Okay, that's what they're talking about. That big tear, that flap, bless you. You're welcome. Then it's, you know, it's saying that big flap here at the bottom that's torn, right, is getting stuck. Right? It's causing a mechanical block to motion. Okay, so we all got there. Okay. So how do you decide if somebody has a mechanical block to motion? Well, isn't there a part of your exam where you take them through range of motion? Is that it? Yes. Right? So what is a functional range of motion? What do you have to do on a daily basis? Right? You got to be able to get up and stand up from the seated position and sit down from the standing position, correct? Right? So the deep knee bending stuff, yes, it's important, but it's not functional, correct? You don't necessarily have to walk around in the duck walk, as you guys remember from MEPS, right? You guys remember the duck walk? Yeah. So, when I was a MEPS commander, I think some of you guys know that I commanded the MEPS station. I did that just for fun, so allegedly. But anyways, so when we're doing our range of motion testing, then we decide whether or not they can have functional range of motion, right? So the ability to extend to zero, right? That's standing, correct? We understand when we're standing, we're at zero, correct? Okay, and then when we flex, let's say we get down to the throne. Everybody knows what I mean by the throne, right? Right? We're at about 90, right? Don't think about it too hard, sir. It's what you're thinking. Okay? All right, so it's 90, right? So how do we do that when the patient, right? I will give you my Gatorade, but you don't want none of this. How do we decide, right? How do we, for lack of a better term, how do we encourage the patient to show us our range of motion? You would agree that even somebody who's laying down, right? When you tell them to straighten their knee, right, and it hurts, they're going to fire with quads, correct? That's what's going to hose you on a lot of your physical exams for the knee, is that you don't get their quads to fully relax. Okay? But is there a thing you can do where you go from the laying down, so the part at the end of the table is out, right? You put that in, and you have them sit up. Will gravity take over? Gravity will take over, right? So you have them scooch forward just a little bit, and then you can actually take them a little bit past the ID as well. Does that make sense? So those little tricks you can do, right? Because when you call me on exam, you do your physical exam, excuse me, and you call me. Don't call me during your pants. I won't answer. Okay? So, but You call me and say you cannot do a range of motion exam because the patient has too much pain. What do I hear? Challenge accepted, right? Because no matter what, gravity is 9.8 meters per second squared, and you can't fight gravity despite what that band is named. Okay? Your gravity will take over, all right? And you're not going to want to hold their leg up the whole time, so they will declare themselves, okay? And then if I'm doing my McMurrays and I'm getting that significant clicking and popping, and we're talking about significant. When you feel it in phase 2, you'll remember, right? Because does every bucket handle tear become engaged and incarcerated? No. Sometimes it comes and goes, and sometimes over time that tear can propagate again, right? So they can change over time. But if it's truly stuck, when you do the range of motion, you should be able to discern that. Okay? So what's the Thessaly test? Is that test where you have the patient? We're just going to wait for you till you get back now. I can't. I wouldn't. But that's probably what I sounded like. We're doing the Thessaly's test, right? You guys know how to do a Thessaly's test, I'm assuming? Correct? Yeah? Or you think you know? Okay, we'll figure it out next week. All right, I'll pick somebody and we'll see. Right? But it's important to understand which one is actually better. Is it the McMurray's or the Thessaly's test? Yes, it is. Because again, like I told you before, when you do a good McMurray's, you should actually be able to discern how it's going around. Right? So when you do a good McMurray's, you should be able to discern again what zone, if you will, or what portion of the meniscus is actually getting engaged if they are having some kind of catching and locking. Because that's what it's called, right? When we're talking about that incarceration, right? It's either it's permanently incarcerated or it's not, right? And sometimes, not all the time, intermittent versus continuous, right? So that's what we're talking about there, okay? So Thessaly's test is one of those tests you can do in case you can't get a good McMurray's, and that's what everybody says, right? They're like, I just do the Thessaly's because I can't get a good McMurray's. Well, you have to decide for yourself what kind of provider you're going to be. Is it that you can't get a good McMurray's because it's the patient's fault, or is it your fault? I'll just leave that there. Okay? Because the Thessaly's may not tell you much. Okay? Makes sense? Thessaly's is very, very, very not useful. But it's something we do. Okay? It's something we do. Incidentally, when somebody becomes incarcerated or trapped, locked, right, like I said before, those are all the same term. When I get called from the ER, right, do I ask them to give me 10 cc's of lidocaine, inject it into the knee after I get consent, of course, and then do a kind of a modified McMurray's to unlock the patient? I do, correct? So Thessaly's is sometimes a technique you can think about to actually unlock somebody as well. Sir? There you go. So, because that's the thing about Thessaly's test, right? Is that Thessaly's test is supposed to correspond, and that's a good thing, right? So he's saying, if they have osteoarthritis, won't they still have pain from the Thessaly's test? Is that what you're saying? Yeah. No, I agree. So again, how useful is that? But if the patient says they have anteromedial pain versus anteroposterior pain, right? And you're able to correlate a tear on an MRI based on you viewing the coronal, the sagittal, and the axial, putting all that information together in the 3D model, then that's useful, right? Does that make sense? So that's useful. But can patients have pain with every test because they have arthritis? Yes. So that's not useful. That's what I'm telling you. That's what makes it non-specific and and very little sensitivity as well. Right? Good to go? Good question. Did I answer it? Yeah, you just didn't know. All right, so weight bearing knee radiographs, so that's important to understand. You remember how we talked about medial compartment, lateral compartment, posterior compartments of the patellofemoral compartment, right? So they can have collapse of those compartments, right? So you would agree that when you have to check and see what that relationship is, or that alignment, right, that you should get a weight bearing film, because if you don't, you're not putting stressors on the weight bearing aspect. Yes, you would agree that, right? So you have to get weight bearing views, right? So if you're doing a knee exam and then you order non-weight bearing views because you're afraid that the patient's going to be in too much pain, there has to be a diagnosis behind that, because radiographically you'll get the images, but diagnostically, it's just not as helpful. Does that make sense? So there has to be a reason why you would get non-weight-bearing films. But as a rule, you would want to get weight-bearing films. So you can determine whether or not there is a change in the alignment, that relationship between the tibia, the condyles, and the plateau, right, etc. Right? And assess degrees of OA, right? Again, when you're talking about loss, LOSS, like we outlined before, you know, that criteria for determining loss needs to come from radiographic findings, which are best elucidated through weight-bearing films. Okay? Well, what's the confirmatory test? MRI. And if you're concerned about meniscal tears, should you also look at all the ligaments in and around the knee? And that's a really good study to do that as well. Does that make sense? So you're doing a complete, or as my clinical group would say, what is it? Focused exam? Yeah, I'm not really sure what that is still. But it's like complete exam, okay? You see the white arrow there? What kind of tear is that? Right? What kind of tear is that? Yeah. How would you describe that? I'm going to leave that open. Okay, I'm going to leave that open. Right? Because I'll be honest with you. Depending on what this is, right? So we have three different views here. Would you agree? This is a coronal view, this is a sagittal view, and this is an axial view, correct? Again, coronal, sagittal, axial. Okay, why do you think it's important to look at all three? Because the orientation of the tear itself is not the only piece of information you need. You need to know whether it's what aspect it is, right? What portion of the meniscus itself, and also is it anterior, posterior, and what's the orientation of the tear. And that's where you get some of this terminology here. This is more talking about the orientation. So does that look like a radial tear right there? It does, doesn't it? Okay. So there you go. So how do you know what kind of tear this is? Unless you look, you have to, again, it's take all that information together, put it all together, and then decide it's a radial tear of the anterior or posterior? Posterior, correct? Okay. There's a lot going on there. But I'm just telling you, that's how we do that. Okay, so you're like, how do they know? Right? How does a radiologist know? Right? So that's what we do. We do all those things and put it all together. Good to go? Okay, and guess what? If the patient has a positive MRIs, but they don't have pain on the medial side, yet the MRI shows a medial meniscus tear, is that the patient's issue? What if all their pain is lateral, right? But the MRI shows a medial meniscus tear? That's what I'm asking. Okay? Do we treat MRIs or do we treat people? People, correct? So that's why, again, if you're just reading the report and you're not doing a good exam, you're only getting part of the picture. Good to go? How many patients get sent to me? Dramatic pause. From primary care saying, the report says the patient has blah, 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 blah. And I'm like, all right, great. Where's your pain? Nowhere that report says anything, right? And in fact, the area that I'm concerned about on exam is normal. I mean, you have clicking on the medial aspect anteriorly, but the report says that you have tear, and I looked at the MRI, I can see what the radiologist is talking about, right? Has anybody been in a radiology suite? Their screen is like this big, right? If they miss it, they got to get a vision check, right? It's huge, right? So they can see those tears like in real time. Right, but how many times do I disagree or agree and then say, well, that's not the patient's issue? Good to go? Okay, makes sense? All right, so don't just read the report, right? Especially when it comes to meniscal tears. Because it's kind of like those, any ligamentous tear, is that what is the patient's physical exam telling you? Are they having instability? Right? In this case, are they having catching and locking? And where is their pain? Okay? So what's the outcomes of disease? So it alters their mechanics. So when we're talking about meniscal tears, right? Well, patients alter their mechanics, basically change their patterns of either flexion or extension or physical activity based on their pain. Yes, right? So, and that those meniscal tears can accelerate cartilage degeneration, which, oh, by the way, once we break down the cartilage, where are we? Bone on bone, correct? Right? So that's when it tends to be more end-stage osteoarthritis. Are we all good with those definitions? I hope so. I've been trying to slowly give it to you guys. right? Build it up, build it up, build it up. How is this all going to relate? Now we're getting to some of that. Okay, makes sense. So if there's a question about that, it's fine. Just ask me the question. Okay, dreaming. All right. So you've decided, right, at this point in your training, that I don't know, downloads is crazy, right? That may be true. But I will tell you this, you don't just get MRIs of everybody and just wait and see what the MRI shows, right? Because when you call me on the phone, what do you think my question is? Am I just going to bear witness to the meniscal tear, or do you think I'm trying to figure out if the patient needs surgery? Right? I'm trying to figure out if the patient needs surgery, correct? Because if it's a chronic meniscal tear, now we get into some terminology, right? Versus an acute meniscal tear. Do people that live active, vigorous lifestyles, right, have chronic meniscal tears on MRI? Yes, right? So a lot of times they will improve as long as they're able to improve something about their biomechanics, right? Maybe drop a little bit weight, right? Things like that. Get more flexibility. We talked about hamstring stretching. We talked about quad strengthening, correct? Right? So a lot of times if you change those components and make the knee move better, right, it can diminish some level of their pain, right? But if somebody's having debilitating pain, you okay, ma'am? You're welcome. We were holding our breath. If I did that, I'd pass out. So, but when we're talking about this, we're trying to understand what when you call me on the phone, I'm trying to understand, like, I'm listening to you, sort of, but I'm trying to understand what you're telling me. Like, why are you calling me for a meniscal tear, right? Why are you calling me, like, on the phone, like the call person, right? If it's like a clinic courtesy thing, cool, no problem. But you're calling me on the call phone, so you think you have a bucket health tear? So what kind of questions do you think I'm going to ask you? What's the range of motion, right? Where's the thing? How long has it been present? Is there any history of trauma? You see what I'm getting at? So if you got an MRI, and I'm not trying to pick on it, but I'll pick on myself, right? I'm third game. All right, if you got an MRI of my knee, I know what my knee looks like. My right knee is trash, right? And so I used to have mechanical symptoms, and then, I don't know, I think my meniscus just said, forget it. We're just going to stop working for you, and it's not going to cause pain anymore, right? But when I was having some mechanical symptoms, what do you think they said? Well, we can go in there, we can clean it up, and we can repair it, right, depending on what we find. So what's the point of that comment? Do you think that if it's a meniscus tear and it's acute, it's going to be repairable more so than if it's chronic, kind of ratty and torn up and chewed up? Yes, right? And there's more to it than that. It also depends on the zone of the tear. I won't get into that too much. I would be happy to discuss that if you guys want. But basically, the vascularity of the meniscus, depending on where the tear is, if it doesn't have good vascularity, even if you repair it, it won't heal. There's no blood supply to it, right? Think about this, right? So if you don't be sad, if you call me on the phone and I tell you, I said, I looked at the MRI, I've heard what you have to say, and just refer the guy. I'll see him like first available, right? Don't be mad at that, right? It just means that I looked at the MRI and decided this guy has a very low chance of getting a meniscal repair because of what the tear is. Does that make sense? So there's no urgency in that. Okay. Does that make sense? I hope so. So no mechanical symptoms and degenerative tears, that's where that comes into play. Okay? So old busted knees, right, with no mechanical symptoms. So again, the question I'm going to ask you is, what's the range of motion? Okay? There you go. That's how I'm going to get that information. So NSAIDs rights to TD modification of physical therapy. How many weeks are you going to put in physical therapy? I hope you guys know my ortho math by now. 6 weeks, right? 6 to 8 weeks. You're going to see them back. Okay, if they're improving, how many more weeks are you going to set them? 6 to 8 weeks, so we'll go with 6, right? And then I say 6 to 8, why? Because how long does it take for Mr. Willick isn't here? He's usually my backup when it comes to delays in medical care. Okay, but does it sometimes take a week or 2 or more for patients to get in? So again, don't start the egg timer when you put the referral in. If they don't get in for a first appointment for 2 weeks, have they done 6 weeks of physical therapy when you see them back in 6 weeks? You gotta put some logic into this, right? But don't call me and tell me they did 6 weeks. Do you think I have access to the physical therapy notes? I do. I can do math. I will do it in public. I can do math. And when I see that they only did 3 sessions, and you say, but I blah, 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 and put them in for 6 weeks of physical therapy, you gotta use some common sense here, people, right? Not you, other people, right? These are some of my pet peeves, by the way. So when it comes to operative care though, again, younger people, do younger personnel, or younger people, younger patients, do they like to do work, play, and sleep? Yes, the work and the play are harder, correct? And the sleep is longer, for sure. I don't know, I sleep a lot now. So, but when it comes to older patients, really you want to max out conservative care. So you really want to max everything out. Do we sometimes do corticosteroid injections for older personnel, older people, older patients? We do, more so than younger people. What's the risk with corticosteroids? All right, we talked about this. It can cause cartilage breakdown, right? It can be chondrotoxic, can affect the meniscus. Some surgeons think it can. Okay, so we really try to avoid corticosteroid injections in younger people. All right, you want a definition? Okay, I'm going to stick with my 35. All right, but I will tell you this: I've never injected anybody younger than 25. Okay, never, just for pain relief, right? Because usually there's more to it than just that, unless there's a history of some kind of trauma. Does that make sense? But as a general rule, again, we tend to say the corticosteroids for more chronicity and or more advanced osteoarthritis. Because what is a definitive treatment for osteoarthritis of the knee? What was that? What was that? A new knee, yes. And how do we say that in medicine? Total knee arthroplasty? No, it's TKA, right? So I'm going to replace it. You're not wrong. I just want you to use your big words. Okay? So, but if they have a locked knee with loss of passive range of motion, then you're going to refer them acutely, urgently, emergently, whatever term you want to use. You're going to call somebody. Make sense? Would you ever send somebody home with a locked knee? I'll find you. Right? So peripheral tears. This is what we're talking about. I mentioned this earlier when we're talking about the blood flow, right? Peripheral tears tend to do better with healing because they have more vascularity, more blood supply, and less peripheral tears then, right? So more towards the inside. If they're torn, kind of ratty and frayed, we may actually just go in there and shave that down and we can't repair it. Okay? Makes sense? And we know what a repair is, right? We keep talking about this. A repair is where you took what God gave the patient and repair it. You take one end and you get into the other end, right? Right? Makes sense? So we're literally going to do that, but we do that with certain techniques. Okay? You see this here? What kind of tear is this? That tear right there.
Meniscal.
Yes, exactly. I appreciate your humor. Because I don't know either. Okay? I have no idea. Okay? But that's the way you confirm, right? So you would agree that this end and that end is not curled up more posteriorly, right? They're supposed to meet, right? Those two ends are supposed to meet. Okay, so how do we get a true sense of whether or not sometimes things are going to be repairable or reparable, depending on if you're from the UK, right? You look at it. You literally stare at it and say, I think I can put that to that, right? But if you look at it and decide that it's in the zone that has low, very little blood flow, what's that? Peripheral tears. Then you may say, well, I just have to shave it down. Okay? Is that called a debridement? We're using our words together. Okay? So that's an arthroscopic debridement. Okay? For large, we'll probably add non-repairable tears. Okay? Arthroscopic debridement. Okay? So it's not a big incision. You just put a porthole on one side, using your landmarks again. Right? You put a porthole on the other side. On one side, you stick in a camera. On the other side, you stick in an instrument, and you start whittling away. Okay? Make sense? That's it. That's what they're talking about there. So less meniscus equals less shock absorption, which equals more OA. Does that make sense? Yeah. So why does OA keep coming to the discussion about meniscus? Because if you take away the shock absorbers, the bones are going to meet, right? The bones are going to make more contact. Does that make sense? So that, by definition, is progressive degenerative osteoarthritis. Good with that definition? Okay. More OA. So do I ever tell a patient that after we do a meniscal repair versus a meniscal debridement, that they're going to be pain-free? Should you ever tell the patient that ortho is going to make the patient pain-free? I'll find you. Okay. All right? Because you're wrong, right? Because is it gonna change your biomechanics? Absolutely. So red flags, decisions, I put it in bold gold, not red. If they're having mechanical symptoms, especially if they're locked in flexion, right? Or extension, but flexion usually, right? You need to call somebody. Do not send that patient home on crutches, right? Looking like a curled up pretzel. Okay? Ligamentous instability, well that makes sense, right? If for some reason you discern that they have a peripheral tear versus a non-peripheral tear, really that's how I say it, right? Because peripheral tears, are they more repairable? Yes. Okay. So that's all it says there. I don't think I would ever ask you that question. There's more to it than that. But pain refractory non-operative treatment, so somebody continues having that clicking and popping or McMurray's always positive, right? So what's a positive McMurray's? Is it pain, or is it pain and clicking, or is it painful range of motion? We'll decide that next week in the lab. But I will tell you this, if you just put positive McMurray's, that tells me nothing, right? Positive McMurray's is positive McMurray's with a click to the medial joint line, or the lateral joint. See what I'm getting at? Like it tells me, that tells me more, right? Because there's no lateral McMurray's in the document. There's no medial McMurray's in the document. You're just putting a positive or negative, so you gotta put more. Does that make sense? Right? So I'm trying to help you write the referrals. Okay. We'll get into this. All right, osteonecrosis of the femoral condyle. So, which condyle are we talking about here? Man, nobody loves the mediofemoral condyle, right? Mediofemoral condyle gets everything. Gets all the bad attention, all the good attention, depends on how you look at it. But what's the most common condyle, femoral condyle, that gets osteonecrosis? Medial. Why? Because it's the weight bearing. Is osteonecrosis death of bone? Is there usually some kind of trauma or some kind of preceding factor that causes this? Yes. I know I owe you guys some sayings, right? Some of you guys have looked it up for deciding what causes osteonecrosis versus avascularity. Okay? We'll get there. But I will tell you this. It's the fact that the medial side is the weight-bearing side that tends to exacerbate this. Okay? Regardless, of the causative factor. Does that make sense? A lot of words there. All right. So why is this picture here? So when you look, right, and you see this picture, it tells you that you go from a little area that could have some bone marrow changes, right? Some bone changes, and then to areas where there's collapse, right? And then as you progress to stage 4, right, then there's basically a divot or an area of missing bone, right? So again, is this always going to be seen on radiographs? No, that's more so if it's been here for a while. So if you have a suspicion about osteonecrosis or bone death, you've got to be aggressive about looking this up, okay? And what kind of patients get this, okay? Women, 3 to 1, older than 60. Aha, so we got a number now, okay? They're getting to that point that Britannica UK encyclopedia says that that's not middle age anymore. Okay, that's older, okay? 60, right? So 62-year-old female with acute onset of medial-sided knee pain. This is part of your differential. Make sense? So a 42-year-old female with medial knee pain, should it still be in the back of your thought process? Yes. But then more so, you should be thinking about meniscal tears. What's the most common kind of meniscal tear? So you see how you think about this, right? You're going to start thinking in these terms. Okay, don't call me and say every patient with a meniscal tear has osteonecrosis. Because as soon as the words 42-year-old come out of your mouth, I'm like, oh, good. Really? I mean, it's possible, but what's the more likely? That's right. Older than 60, so it tends to be something where you look at that list there, right? As we go down this list, with the exception of Gawker's disease. Have you guys talked about Gawker's disease? Erlenmeyer-Flass deformity, etc. Okay. All right. Erlenmeyer-Flass, I don't know if we get that. So, but it's a deformity that's seen blushing. All right, but I don't want to get into that. Again, I want to tell you my take on it, but it's one of those things where basically you're looking for zebras, right? Really where things are not very common. Okay? So again, these patients sometimes have weird medical histories. By weird, I mean their manifest is long and not distinguished. Yes. Okay. But again, you got to get a good history. Renal transplant, what kind of people get renal transplants? Diabetes, right? Their kidneys hate them, right? They've been burned out, literally, like light bulbs from all that sugar. And there's ketoacidosis and all that craziness. Okay? So again, these tend to not be the healthiest. So why am I telling you this, right? Because when you're reading vignettes, scenarios on pants, right, they're going to give you the common presentation stuff, even if that's something you don't experience in practice. Good to go? So that's how you study these things, okay? All right, good to go. So subchondral collapse leads to OA. So we talked about that. Good luck, sir. I hope they find your arm. So when we're talking about this, the subchondral collapse. So that's subchondral sclerosis that leads to subchondral. I got it. I remember this now. Okay, good. All right, so then we're on OA again, right? Sudden sharp pain to the medial compartment. Sudden sharp. Okay, acute onset, spontaneous onset, right? Things like that. Those are the words that kind of usually get used in scenarios. Okay, there's no preceding trauma or injury. Okay, right? Constant pain in words of activity, and here it is: sharper pain than OA. Does OA tend to be more of a chronic nagging pain that gets a little bit better as the patient warms up the joint? Okay, so remember that. Because this is how you're going to start deciding what is OA and what isn't, right? Because OA is everywhere, but osteonecrosis of the medial femoral condyle is not. Good to go? Do you have a question, sir? No, okay, sorry. I thought you saw me wrong. So what are you going to see? Mild diffusion? Okay, sure. Okay, so mild diffusion. Does diffusion tend to get worse as the day goes on? Yes. Right? That's another key characteristic. I'll throw that in there. Loss of range of motion. Okay. Does it hurt to have the knee fully extended and weight bearing? It's the medial femoral condyle, correct? It does. So the patient may actually walk in kind of a, not your Nellerberg, don't take pictures, right? In kind of a stoop position, or will they sometimes use an assistive device, as in a cane? Okay. All right. This is a 60-year-old. Yes, sir. Not potentially, but in this case, it wouldn't be very helpful. Yes. You're welcome. All right. So his question was, will you have a positive density test? Probably. Well, you could have a positive everything test.
Yeah.
Would the varies be positive necessarily? Get back to you on that. Okay. But all I'm telling you is, if you have a strong suspicion of osteonecrosis, it's not just because you're saying to yourself, this patient has medial side knee pain. Who gets this? 60-year-old females, correct? Greater than 60? Correct? So again, it's the patient populations as well. Does that make sense? So it's just as important when it comes to orthopedics, and I would argue in certain other disciplines as well, is to understand what are the most common presenting patients when it comes to certain conditions. Good to go? Okay. So if they walk around in the flex position, right? They're sick. I had a point. I'm sorry. I think I derailed. When a person is 6 years old, sometimes they just use a cane just because it's more comfortable for them because they have back problems. Yes. So the important thing to understand when it comes to assistive devices, right, is what was their pre-onset of injury or onset of pain state. Make sense? You'll hear that said many times. Okay, what was their pre-injury functional level, things like that. So it's important to understand that they just started using the cane because they got it from somebody, right, and they felt it was helping them walk better, or were they using a cane before this started? Does that make sense? Because that helps you decide a couple of different things. So the history is important. Okay? All right. Tender displacement of the medial femoral condyle beside the patella. Okay. So that's going to be a very specific pain, correct? That medial femoral condyle, you've got to know where that is, right? And is it going to be more to the medial side, closer to the patella? Yes. Isn't that what these pictures are showing you here? Is that the patella right there? Yeah, now I put it out. Otherwise it looks like Charlie Brown's picture, right? But I'm just telling you, that's what they're getting at. It's going to be medial on the medial femoral condyle. Good to go? All right, so it's going to be a very specific thing. Okay. It's not going to be that generalized medial joint line pain. It's going to be like, oh my goodness, this is a 62-year-old female with medial aspect of the medial femoral condyle. That's how you say it, by the way. pain, acute onset, who is a renal transplant patient, who was a poorly controlled diabetic, who likes to smoke and who likes to drink. I'm not judging, I'm just saying, right? And those are all risk factors, correct? And she's on chronic medications for other conditions. So she's got systemic disease as well. You see the picture on point saying, right? Why am I saying this to you guys before I put you on break? Because I got asked last semester, really good question. It was like, well, how am I going to know, right? I'm telling you, you're going to know because these are not normally very healthy people. Okay? That's how you're going to know. This isn't just some 62-year-old triathlete, right? Because they're out there, right? The events are like 20 meters long, but still, right? So, you know, these are not those people. This is certain patient populations, so you will be like, I need to be concerned about this with this patient. Make sense? All right, let's take a break. Usually, we'll try to do But if that's, if you refer to something 3 months later, it's not getting caught at all.
Interesting.
It's only confusing because he's going. We're not.
Yeah, I never. They go to the hospital.
This is more like.
Oh yeah. Did we have to tell them? Did you get back to each other with the cups?
For the ED, we just test everything. We don't tell them.
So there's two different things. There's two different things. There is medical, which is the rule about like if this person is like shit they're high on drugs and like you're drugging someone punitive. There's two different. Because my wife does that. So like when they in urgent care, there's a certain process they have to go through for like drug testing, whether it's like physical or it's like a police order one versus medical. Like I'm doing it, but you gotta figure out why are you like this. Those are two different drugs.
But if it's like a primary
Primary, we have to tell them, hey, we're going to test you on
Well, yeah, because I mean, there's no really.
for the ED, we don't, we just do
Yeah,
all
there's no indication of primary care that you do a medical one because
Where I live now,
what would you call it?
all day, every day, I actually love living out there. I know. So is that just what you learn how to text?
It also can like
Occasionally, I would see like 8
Oh, yeah, like
my friend, she joined the Peace Corps, and they do the same thing with the government, so they do the same thing like I'm still just like on your record, and she knows she got drug tested after during the one time and came up positive for amphetamine, so it's in like 2 days. So she's like 8 and she's like she didn't know. I was explaining to her, no, if you're going in for like an emergency thing or some type of just medical, they don't have to tell you it's not punitive. It's just different because like stuff like people with the military go through your record. So there's something like that.
Y'all give a fucking
Why?
No, yeah, but information, like.
well, then that's no choice to do it now.
I mean, you know,
No, you have to do it now. You're obligated.
The only time we work on that is if we think that maybe it's like we just want to see like, hey, is this the reason why it's not are you having these symptoms? Yeah, they have, we talked about that too. But I thought it was like CMA.
We have questions we don't know iPads. For people that have loaded shirt, I'm not going to get this. Is just more of a so is this a box of shirts?
I mean, you're patient. You can do whatever
No, I know. But what
Well,
I'm saying
the
is,
other one
wouldn't
does-
that give you the suspicion of now, shouldn't this evaluate readiness? If this person just happens to not.
I think you're thinking
You know
too
what
much of like.
Yeah, or because we are technically.
No, you're incentivizing, you're ensuring that you're.
Yeah, but there is some duplication.
There is a
fine line. There's a fine line right on like what versus something you know so in that same theory, someone not doing their rehab being trained to the now they can't but
I think with
we get it everybody. I might open up more on that because I don't have all the answers. It's such a hazy
yeah, we're not like
thing.
Because imagine we act on
The patient will trust you, but like, any state they tell you, they go straight to like, yeah, or like, I don't know. There's a reg somewhere that says something. I just don't know what it is.
I would let the first one ask
Alright, Alright, a couple of good questions on the break. Love it, keep it coming, right? Try to address some of these concerns you guys have. So when it comes to bucket handle tears, when it comes to this, it helps me turn it on. Still doesn't help. Never mind. Battery's dying. Nope. One second. Okay, when it comes to bucket handle tears, right, when we go way back here, a question was asked, and I think it's a good question, right? So what's the difference between this and this? They kind of look the same, right? What's that? Yeah, so the full thing is, so it's more propagated, right? And the big component of it is this portion right here, okay? Because you know that this is the C out here, this outer portion, right? It's that separated, I agree with that. But that portion right there, that's a flap that's created essentially. Okay? So have you guys heard the term flit bucket handle tear? You have heard? Okay. All right. I acknowledge you, sir. I acknowledge you. All right, so that's what flips, is that portion right there. So when we're talking about this piece right here, then that is free floating essentially. It's not anywhere near approximated to where it's tore from. In comparison to a horizontal tear. Does that make sense? Okay, so that's what we're concerned about. If we let that go long enough, that's going to continue to flip and continue to get cause the need to get locked. Okay, make sense? So we've used some terminology now. It's important to understand. Snap, crackle, pop, right? But when it comes to meniscal tear, then you add the term catching and locking. Amazon? Okay. All right. So when we're talking about catching and locking, right, then we're talking about this kind of pathology where we're asking the patient, are you telling me that you potentially have a bucket handle tear? Does that make sense? Right? And that's, yes, ma'am. You got to share it if you have questions. Okay. Not necessarily. That's why it's important to discern that, though, right? So if you can't do, so our question was, decreased range, I think your question is, right, right? Is that if you have decreased range of motion, right, does that necessarily mean that the patient does have a bucket handle tear? No, but the question becomes, do they have decreased range of motion because of knee pain or because they have a bucket handle tear? Does that make sense? So that's why when you call me and tell me you can't get an exam because of pain, what do I hear again? General is accepted. We have a closet full of medications that we can pull out, right? For example, 10 cc's of lidocaine, inject into the knee. Does everybody know what CFS stands for? Can't feel.
Can't swim fast.
Anything? Okay, that would be CFA, but you guys know what I mean. Alright, so you can numb things up so you can get things moving. Does that make sense?
CFA.
What's that? Alright, so that's what we're talking about there, okay? Did I answer your question? Yeah. Okay, good. need something. Alright, so we understand these, neophymal condyle, osteonecrosis, excuse me, neophymal condyle, these are not necessarily healthy people, right? Okay, so we've established that. So that's how you get them, for the most part, when it comes to testing. Is that real life? Your experiences will be your experiences, okay? Good to go? Alright, early sclerosis, late loss of joint space, correct? So we understand that is when we say, okay, well now we have early arthritis or early degenerative changes if they weren't already present. Not necessarily early meaning based on age, just based on the disease progression. Okay? What's your confirmatory test? MRI. You should jump to that pretty quick if you're concerned about osteonecrosis. Because is that bone death? Okay. So when bone dies, it goes blah blah. Can we grow bone? According to the latest article on CNN, someone's doing it somewhere. But can we do it for mass production? We do. Okay, so that's a point of no return. Okay. Yes, sir. The stage thing is more for your reference. I would never ask you this question. Okay, because this question, I would tell you it's very subjective, right? Because I already told you earlier that it's important to understand whether something is medial, lateral, right? Anterior, posterior, is proximal, distal, right? So you have to have multiple views. Does that make sense? Yeah. So, so you're asking me if I think that this is what stage this is? You would agree that's not stage 1, right? Does it look like stage 2? Potentially. Okay. Let's go back. Right. But that looks, to me, it looks more like this. Do you see this plate right here? All right, once you get the calcified plate, and I'm not trying to hit you, sir, but you see the calcified plate? Maybe on this one here, right? See that plate right there? So I would say it's at least 3. I'm just going to stand here so you can't sit down. Okay? All right. So does that make sense? So you think I get asked questions like that as ortho all the time just to see where I'm at? Okay, especially when I'm working with new surgeons. Okay, I'm looking for that plate, but that is completely because you asked a question. I'm never going to ask you a question like that. Okay. Predict progression. Okay, we talked about this before when it came to collapse. Correct. You want to know what stage the patient is in the disease process to predict progression and also guide treatment. Does that make sense? Okay. So that's the purpose of the MRI as well. Okay, I labeled it. Okay, that's all that says. All right. So when we're talking about adverse outcomes disease, all right, subchondral collapse leads to OA again. Do we want that? No. Right? So we're trying to prevent that, but if it's not prevented, it happens. So then you have what? A treatment plan that attempts to slow this progression. That is the whole goal. Okay? Is there any one good treatment for us? Not really. Once you diagnose something at a certain stage, what's that saying? The cat is out of the bag, right? The train has left the station, what have you. It can be very difficult to promise the patient much because once it's gone, it's not coming back. Okay. So, non-operative, no great options. Very frustrating. Right? Early diagnosis is key. Right? Limit weight bearing and use an unloading brace. Have you guys talked about what an unloading brace is at any point in your training so far? I'm going to take the silence as either you're studying for your test on Friday or that you have not. Okay? And I will tell you this. So when you're talking about collapse of the joint, right, because that's what we're talking about here, or when you're talking about relieving weight bearing on that side, would you agree that if you can use a brace that will kind of hold the knee away from that side and take some of that weight bearing off, that may be better for the patient, not only in pain relief, right, but in trying to slow the progression of the disease? Yes, so that's what the brace does, okay? Is this a custom brace that's fashioned to the patient specific? Yes. So again, these are things that, as you can tell, another reason why you're going to send it to us pretty quick, right? But, yes, sir.
Is that different from like a traction brace?
Traction brace.
Or
Explain.
like would that is that similar to like putting traction on the distal extremity or
No, it's different. No, it's different. So you're talking like a hair traction splint?
Yeah.
No, it is not like a hair traction splint. Okay? No, it's not. Okay? This is different. Okay? I will attempt to find a picture for you guys. Cool with that? And so you can see what I'm talking about. I'm continuously trying to go over to the hospital and acquire things. But credentials work slow. Alright, so anyways. NSAIDs, 11MARCH steroid injection for pain. Okay, we talked about this, right? Can steroids cause advance in the degenerative process? Yes, right? So if you're, I would tell you this, it's probably going to be a decision that's made by a specialist and not at the primary care level. Good to go? Okay. Aquatherapy, right? This is not Aquaman, right? This is not Aquavelva, right? It's not any of that stuff. Aquatherapy is anything in the water because is water low impact? Yeah, in some respects, water is no impact depending on what you're doing, right? Do astronauts train in water? Yeah. So aquatherapy is really good for, again, keeping them moving, because what's the enemy of orthopedics? Stiffness, right? And then operative, I already told you, is no good option. So choose something. You want to replace the joint? Probably more than likely, especially if it's grade 3 or plus, right? You see that calcified plate. Okay. Osteotomy. Osteotomy means you're going to change the alignment. Yeah, you can do that, but this patient is 6 years old. Are they just going to start wearing differently? Yes, right? And maybe that's not well tolerated too, by the way. Arthroplasty, again, that tends to be the thing, right? Arthroscopy, what did I tell you? Arthroscopy is really good for when it comes to arthritis. Whittling, right? You don't want to whittle this kind of arthritis, right? Because there's things that are just completely off. Does that make sense? And it's subchondral, right? Right? So you're going to whittle subchondral. So a lot of times, unfortunately, the option becomes arthroplasty. Okay? So there's your exposed distal femur with the lesions in the medial-femoral condyle. Now that you've had a chance to look at it, which condyle looks bigger? The one that's circled? The one that's labeled medial-femoral condyle? You see what I'm getting at? Right? So, not your question, right? I may have added that red circle too, just to make sure we know what we're talking about. But that's what we're talking about. See how, like, if you look at a picture, it doesn't really make sense. When you look at an image or you look at a condyle, right, because it's open and split like that. This is an incision, and the patella is reflected. This is a large incision. This patient is undergoing a total arthroplasty, I promise you that. This is the look I get, right? And before I start measuring for cuts, and start using big saws to cut that bone. Okay? So this is good sometimes. But it's still sad, right? Because this is not, these usually aren't the healthiest patients too. So there's still a concern about recovery from the total knee arthroplasty as well. Okay, I need to keep moving, I'm getting excited. All right, so NSAID risks, always there, right? Stomachs, sprains, soft squishy guts and stuff like that, right? So know your patient, use the right ones. Don't start with a big gun unless you have to, right? So risk to neurovascular structure surgery, sure. That seems like an extreme thing right there, right? Do we find blood vessels and identify them and move them out of the way? Do we find nerves and make sure we know where they're at? What's a nerve you think we're looking for here? Peroneal nerve, all right? Peroneal nerve, all right? Is that a retractor right there? All right, where's the peroneal nerve? Right about here somewhere, right? Is it proximally on the lateral side there? Is the, what? The proximal, what bone is that? Femoral. Proximal. I'm not lying to you, Fraser. That's what it is. All right. So that's where we put retractors. So again, you're not just putting retractors in there and just pulling for dear life. You got to make sure you know where that nerve is because it doesn't take an insult like it. Okay. So if I were to ask you a question about surgery, right? What do you think is fair game? Is peroneal nerve fair game? For example, I tell you that a patient underwent a total arthroplasty and now they have foot drop. What nerve was affected? Aha! So we put our knowledge of anatomy, our knowledge of nerves together, and our knowledge of physical exams, and we came up with the best answer, correct? You need to know nothing about total arthroplasty to answer that question, right? You could know nothing, but you just know that it's in or around the knee, and that they have foot drop. There you go. You're welcome. All right, so risk of overcorrection with surgery, that's always something, right? You make the wrong cuts, both, I don't want to get into this, but basically you can make what's called flexion cuts and extension cuts, right? So you have to make the cuts, not just make the cuts based on what it looks like from the coronal plane, but how it's gonna look like when the knee's flexed and when the knee's extended as well, okay? So there's more to it that goes into that. Those guides that are put on the tibia, and then those guides that are put on the femur, and those cuts are made according to those calculations, okay? So that's what they mean by overcorrection. If you overcorrect, right, especially if you cause varus, right, there's a saying in orthopedics, thou shalt not varus. Ever varus the patient, because which compartment is the most commonly affected with osteoarthritis? And what do you cause if you over varus or you put the patient to varus? Medial compartment narrowing, pressure, right, increased weight bearing. Now thou shalt not varus. Carpia. Okay. I said it right. All right, so you did all this stuff, right? This is thrown in there as a G-whiz, right? Let's get back to trips, right? What if they have disproportionate pain and they have a history of osteoporosis of the neopermal conduct? Is it possible for the patient to get crips? Yes. But you see what I'm getting at with this? Like crips is not something that's is osteonecrosis of the neopermal condyle very common in every female that's over the age of 60? No, but if they have pain out of proportion, or if they got treatment for it, and now they have hyperesthesia, what were the other aesthesias that go with it? Paresthesias, right? What are the skin changes? Right? Flushing of the skin, just call it that, right? Swelling, intermittent swelling, things like that. Crips has to be part of your differential, doesn't it? Right? Crips is weird too. Yeah. So what are you going to refer? Non-operative treatment. Failure. Okay, so they do all the goodness and then they have failure. So out of all that, okay, what do I need you to know? I need you to have a suspicion for it in the right patient. I need you to be able to understand what the imaging does in order to both stage it and decide what stage the patient's in, because it guides your treatment. And I need you guys to be able to recognize the fact that when it comes to the number one thing you guys at the primary care level can do, put them on crutches and make them non-weight bearing. Does that make sense? Okay, because if there's a delay in care, right, then maybe they're weight bearing for weeks when you don't want them to be. Good to go? Okay. Patellar quadriceps tendonitis, why do those go together? We talked about the extensor mechanism, correct? Quad tendon, we talked about the conjoined quad tendon, okay? We talked about the patella tendon, and inserts into the tibiotubercle, okay? That's your extensor mechanism. So therefore, if you're going to have a quad or a patellar tendonitis, then it's painful inflammation, correct? That can be of insidious onset. It can oftentimes be chronic, right? And so that's what the patient is going to describe to you. Right? So what is the most common thing that this is called? Do I call it this? No, because I think it's confusing, but jumper's knee. Okay? All right? Does a patient will look at you and say, I never jump. Ever. Right? It's still jumper's knee because it's patellar quadriceps tendonitis. Right? But it's just trying to get you to understand that these are active patients a lot of times. Okay? They can have a lot of overuse, right? And a lot of like chronicity that comes with this. So what's the usual pattern for this? It's kind of like a wave, right? It's good, it's bad, it's better, it's good, right? So then when you're doing your OPQRST, right, you're asking them what kind of things you do to make it better, and what kind of things you do to make it worse. You may hear things like, I take Motrin every once in a while, and it makes it better. Or I instead of running 2-meter sprints this week, interval training, I went to rowing. See what I'm saying? So there could be an alteration in their workout routines. So it's important to kind of get to that. But the other thing is to understand your anatomy, right? Superior pull of the patella. Where does the quadriceps tendon insert? The superior pull of the patella. Okay? And again, that's when it becomes that conjoined tendon, correct? So when you're reading questions, right, in the future, very soon, right, make sure you're reading the question and understanding what portion of the patella is telling you, right? Because where is the patella tendon? Is that the inferior pole? That's the inferior pole. You see what I'm getting at? So reading the question, right? Reading the question, don't just read it and understand it, can tell you a lot, okay? So if it uses words like tibial tuberosity, you know you're not talking about the quad tendon, correct? So that's an example of what I'm talking about. Okay, so understand those definitions. Okay? The other thing is younger, less than 40, says jumping or kicking sports, right? What else does it say there? Erratic exercise habits, that's what I was talking about earlier. You know, people that do all kinds of craziness, weekend warriors, upset, older, lifting, straining, changes in exercise level, substantial weight gain. Yes, pear is a shape, but if your patient is pear-shaped, we need to ask them, do you normally run 3 miles in one go? No, I've never done this before, I'm trying to get in shape. Okay, good to go. Because you palpated them, and they have tenderness at the superior pole of the patella, or the inferior pole of the patella, and you decided whether it's patellar tendonitis or quad tendonitis. Make sense? Okay. Have you ever run 3 miles other than being changed? Or when was the last time? Hallmark is anterior knee pain. I will tell you this, I hate the term anterior knee pain as much as I hate the term patellofemoral pain, right? Because what does anterior knee pain tell you? Nothing, right? Anterior medial knee pain. Okay, you start working on a diagnosis, a differential diagnosis. Anterior lateral knee pain, got a little differential diagnosis there. But an anterior knee pain, tells you nothing, right? So you don't want to use that term as a diagnosis, right? It's a symptom, not a diagnosis. But commonly, they'll begin the exercise, and they'll start having some discomfort, and after sitting, preceded by exercise. So they go from like a real strenuous activity and they sit down, and then they have pain, okay? When you sit down, think about this real quick, right? When you sit down, is your patella driven down into your tibia? Because there's a stretch on the patellar tendon and the quad tendon. It's almost like a rubber band that's tight, correct? So that's what they're describing there. There's actually a sign for that. Do you guys know what it is? Theater sign. Gold star. Okay? Theater sign. That's what it is. And theater sign, again, is terrible. Theater sign can be present for anything that involves the anterior knee or just the knee in general, correct? Because what you're doing is you're putting the extensor mechanism in stretch. Make sense? You're compressing that patella. Okay? Good to go? So not useful. Worse with knee extension activities, well, that makes sense. It's the extensor mechanism. Holy Jesus. They have pain when they extend their knee. There we go. That's what we're talking about. Right? So that is important to understand. If they describe an extension of the knee activity, you got to be able to pick that up. Okay? All right. So, pain with resistant extension. I'm not going to say I don't do this, right? But if somebody has like pain here, right, and you tell them to resist against you, does that really help you as much as palpating certain point landmarks and saying, oh, okay, so your pain is more so here. Right? But it can be useful in trying to decide if it's kind of equivocal. Is it flexor, is it extensor, excuse me, is it the quads or is it the hamstring, basically? Make sense? But there's other things involved. Okay? So, if you guys been taught to do your resisted extension like this, I like this. You can do that in the back of a coyote. You can do that anywhere. You know? It doesn't take much space to do that. Okay? You literally just put them in that position with your hand there, and you just have them resist. They don't have to move up, right? Because the leg is going up, correct? What's the difference between up and anterior? We discussed that the other day. All right, but they're resisting you. It doesn't have to move. They just have to resist you. So it's maximal effort. So when you do that test there, do you tell them push hard? Yes. Okay, that's what you tell them. Okay? But again, it doesn't have to move. Okay? So when you get radiographs, this is an important thing. Have you guys learned what the difference between an enthesophyte and an osteophyte is? No, not. Okay, good. This is important to understand. Okay? An enthesophyte occurs, right? Does that enthesophyte necessarily have anything to do with a joint? Negative. But does an osteophyte have anything to do with a joint? Yes, it does. Okay, so we decided that. So then an enthesophyte, I'll tell you this, right? I'm not going to throw a bunch of Latin at you. You guys probably hate it, right? Why don't you learn Latin? But when it comes to enthesophyte, you would agree that there's a tendon that inserts right about where that white arrow is, correct? And there's another tendon that inserts where that white arrow is, right? So what that is that little area where it's calcified, that's at the point between a tendon and bone. Make sense? Okay? Now, it can get tricky, and when you think about it, that that's intra-articular, isn't the patellofemoral compartment part of the joint? Yes, but the difference here is that it lives in the area where a tendon inserts into a bone, okay? You see how it's different now? All right, so that's the difference between an enthesophyte and an osteophyte. So when you say enthesiopathy, right, enthesiophytes, right, pathology involving enthesiophytes, you need to be able to discern that and understand they're not talking necessarily about osteoarthritis. Good to go? Okay. What do you think causes this? Throw it at me.
Jumping.
Irritation, okay? Chronic irritation, inflammation, I agree. Tendinitis and calcification, I don't disagree. Right? Because you can see it. Are you supposed to be able to see soft tissue on X-ray? Negative. So it has calcified. It has turned into something that's harder, correct? But would you agree that there's pulling on either end as well? Okay, so a lot of times we term this, especially in certain disease processes, we term this as tug effect. Right? It's been pulling here, it's been pulling here, it's been pulling here, it's inflamed. Right? Therefore, it hardens. Is that a protective measure to keep it from rupturing? It can be, right? But if it becomes too much bulk, can it fracture? Absolutely. So why am I telling you this? Will you, in your practice, get an X-ray report, right? You're going to look at the X-rays. I know you are, right? Will you get an X-ray report that says there's a fractured enthesophyte? Think about this for a second. Is that a fracture? As in, like a bony fracture, meaning like there's bone ends that need to be put back together? Not necessarily, but what are you going to do? Right? This is the most important thing I'm going to teach you today, I think. You are going to document, because you're going to do it, you are going to document whether the patient is able to obtain and maintain a straight leg raise. Okay? Because if a patient can elevate their leg in a straightened position, and hold it at least, let's say, 4 to 6 inches off the table for any period of time, on their own, without being assisted, is their extensor mechanism intact? Yes. Okay? That's it. I'm standing here dramatically, like I'm in front of a ship or something. Right? But I will tell you this, because when you call me on the phone and you tell me all these findings on X-ray, I say, stop reading the report, please. Can the patient obtain and maintain a straight leg raise? And you say yes, I say, that's getting late. You know, put the referral in, I'll see him. Okay? But if you tell me that the patient has a patella tendon rupture, I'm like, I'm confused because I'm pretty sure I taught you that if they are able to obtain and maintain a straight leg raise, that their extensor mechanism is intact. Therefore, they can have neither a quad or a patella tendon rupture. Make sense? Now, if they have painful, right? If they have pain when they attempt to do that, they have tendinitis. Make sense? Okay, so if you see the enthesophyte, again, you're more concerned about tendinitis. Good to go? Hopefully that makes sense. So when at the tubercle, right? So let's talk about this. Osgood-Schlatter disease. You guys want to know what that is yet? We'll talk about it. You guys talk about it already? Not at all? Okay. Osgood-Schlatter disease. So you see this area here, what did I call this again? Pull traction, right? Pull effect, tug effect, okay? So when kids are younger, is this area here an open growth plate? Yes, right? So as they're younger, right, and that open growth plate gets pulled on, not ruptured, just pulled on, okay, it can have this appearance, correct? Answers always. Whatever, apparently. All right, so that was your cue, sir. All right, so here's what it is. So do adults get patellotendinitis, or do they have a history of Osgood-Schlatter and have patellotendinitis when you see this on X-ray in the adult? That is the question. It's the chicken and the egg argument. It's the classic one, right? So I will tell you, if you see this and the patient has open growth plates, you use the term Osgood-Schlatter. Okay? If you see that and the patient has closed growth plates, right, and they're active duty, right, assuming they have closed growth plates at that point, right, then they have patellotendinitis. Okay? By definition, is it, yes, go do the Google searches. Is it possible for someone to call a pediatric patient have patellotendinitis? It is possible. But again, that's why very commonly what's taught is a history of Osgood-Schlatter disease, right? Because that's what this is. It sounds terrible, doesn't it? Osgood-Schlatter disease sounds like a terrible condition. So really, just again, that tug effect. Do the pediatric patients have anterior knee pain? Yes, we'll talk about it, okay? But that's all they're talking about here. Make sense? Any questions about that? We're going to get into OSD later, I promise. Okay, I just want to introduce that. So if you see a question, right, and you see answer choices, and the patient's pediatric, and you choose patellotendinitis in my course, is that the right answer? No, right? Okay, good. All right, MRI recapitulatory cases. X-rays are usually good enough, right? They're good enough. But if they have recalcitrant cases, because what are we talking about here? When it comes to the patella, right, because we're talking about patellotendinitis, right, or quad tendinitis, we're either looking for ruptures, tears, or we're looking for degeneration, correct? So is an MRI a really good way to get a look underneath this patella? It is, right? And that's where you guys probably already heard that term patellocondylation. You guys heard that? Yes, you have. Okay, was that in radiology? Okay, so patellocondylation. I will urge you this. Don't just label every patient with runner's knee as patellocondylation. They're not the same thing. You have to have evidence of chondral wear, right? The chondromalacia itself, in order to call it that. Make sense? You just saying that the patient has theater sign, that they have pain when they do obtain and maintain a straight leg raise, and that they have pain when they run, that is not enough criteria to call it chondromalacia. Good to go? Okay, so that's a diagnosis based on imaging. You'll do it, right? But it's just not proper. So when you hear me correct you in practice, not you, but people in practice, right? That's why. Because I'm like, oh, do you get an MRI? And they say no. I'm like, I'm confused. Because I can't diagnose it without getting an MRI. So how are you able to do it? All right? Make sense? All right, there you go. All right, prolonged pain, rarely tendon rupture. Okay? Do you think patients that have a history of chronic steroid use, chronic tendonitis, can go on to have quad or patellar tendon ruptures? Still no answer. Okay. All right, so when we talk about treatment here, very, very common stuff, right? All the NSAIDs, rice, activity modification. What did I tell you? What are you going to put in your PT consult? Hamstring stretching and quad strengthening, correct? Was that what's in yellow there?
Yes.
Yes. All right. Enthusiastic. All right. Gradual resumption of activities. Okay? So that's that thing where you're going to tell the patient. Okay. Has anybody here sustained an injury? Right. Oh, everybody. And they've been sent to physical therapy, and they give them a walk to run program. You guys heard the term walk to run? Okay. It's a ramp up. It's a ramp down, and then a ramp up is the way you think about it, right? So you don't just go right back to running 3 miles a day, right? If you haven't been running 3 miles a day for a few weeks because your provider told you to chill, right? Makes sense. So again, it's gradual resumption of activity. That's one example. All right, blood cakes, sure. Whatever. All right. Yeah, so what are if you treat them, okay, I will tell you this. I very commonly discourage people from doing corticosteroid injections in and around the patella tendon. Definitely the quad tendon, okay? But even with a patella tendon, I usually tell people, let me just see the patient and see, all right, just to make sure, right? Because if you rupture that extensor mechanism, is that big surgery? Yes, we'll talk about that, okay? So just be careful with that, okay? You get it? Yeah. All right, so persistent functional impairment, sure. If they can't obtain or maintain a straight leg raise, can they walk normal? No. So again, you call me on the phone, tell me the patient sustained a quad tendon rupture, and they walk into my clinic, I'm very confused. All right? It just doesn't make sense to me. Makes sense? All right, so now we go to the end of the spectrum, right? I'm going to finish this topic, I'll let you guys go, because apparently you got discussion. Is that what we're calling it? Sure. Okay. So ruptures. So that was tendonitis, right? So remember I tell you guys there's always a spectrum, right? So tendonitis is my left hand, rupture is my right, right? And most patients exist somewhere in between, correct? All right. So if guess what I ask patients if they come in and say they have a patella tendon rupture? Do you have a history of quad tendonitis? Right? Because very commonly they do. Make sense? So again, it's a continuum. All right. So when we're talking about rupture, let's not belabor this. It's a disruption of the extensor mechanism, either proximally or distally. So again, this could be likened, remember, to that biceps tendon, right? The head of the biceps, the the meaty part, right? Whether or not it comes proximally or distally, but what is that component we're talking about here? It's the patella, right? So let's go with this, right? When we discuss it, we're talking about the patella as being the one that's going to shift based on what's still attached, whether it's proximally at the quad tendon insertion or distally at the patella. Okay? Make sense? Okay. So what's the normal mechanism of injury? Fall on a partially flexed knee. Okay? So what does that mean? They literally fall with their knee bent. So the way I document that is fall into bent knee. That's all they're saying. Okay? So direct blow can cause fractures. Yes. Okay, when it comes to a direct blow to the patella though, right, it really depends on the fracture pattern as to whether or not they have disruption of that extensor mechanism and to what extent. Okay? Alright, there's a lot more to it. When we're talking about ruptures, for the most part, I talk about an actual disruption of the tendon itself. Make sense? Not necessarily the patella. Okay? So what's the usual here? Quad. This is what your book says. Okay? You can disagree with this, especially on the military, right? In the military, it doesn't always follow this rule, but the epidemiology, the studies, all the preponderance of data says that quads, who gets them? Males, 40 to 60 years old, and patella, when I say patella, I mean patella tendon, right? Is what? Black male, 40 to 60 years old. So the age is the same, but the race is different, right? Skin color is different. Okay? So get that in your head, and then you go to phase 2, and you won't see that. All right, because our military people more active? Yes, right? So do we see quad tendon ruptures in all ages? Yes, craziness, insanity. Right? And again, they can be due to patellar fractures. Think about it. Right? So could it affect both sides? Yes, that's when that's different. I will not give you a patellar fracture and ask you to tell me what the exam is like. It will be a clear-cut quad tendon rupture or a clear-cut patella tendon rupture. So what do I mean by clear-cut? Well, words like large palpable defect will be in the vignette. Right? If you have a large palpable defect of the conjoint tendon of the quad, right? The quad conjoint tendon, is that a quad tendon rupture or is that a patella tendon rupture? Right? That's what this is, right? Right? That's what that is right there. Look at that picture that someone found for you. Collection. All right? That's a great picture. I mean, that's a gap, right? You would agree that you could put like an entire shot of your favorite coffee in there. Right? Right? And so where is this? This is distal to the inferior fold patella. Right? So that is probably the patella tendon, correct? What a great picture. Right? And so what can't you do? The one on the right. Okay? Which is what? Obtain and maintain a straight leg raise. Right? There you go. That's your first clue. Now you got 50-50, right? Is it quad or patella tendon? Don't leave it to chance, ladies and gentlemen. Figure it out based on the described deficit. Right. Here we go. All right. Así que vamos a hablar sobre este español de patela baja y alta. Okay? So what we're talking about here, right? Right? I told you guys Latin, you should learn Spanish, you should learn Portuguese. I did. Right? But anyways, what we're talking about here is Spanish, right? So everybody, for the most part, they know the tacos, right? Baja tacos, right? Or the area to go fishing in, right? But baja means low, right? Or beneath, okay? Bajo, beneath, okay? Alta means elevated, or up, or above, correct? So, let's talk about this. We already described that the patella, right, is now the muscle belly in the analogy we use for the biceps tendon, correct? So you saying that, if a patient has patella baja, entonces, ¿qué parte está lastimado? Okay? So which side is intact and which side is injured? Okay? Okay.
No
That's
outflow.
what you're going to figure out in these questions, okay, guys? Right? And so therefore, when you're talking about radiographic findings, and you see a radiographic finding, right? Because that's not a physical exam. You can't see the gap, correct? You can sometimes, right? But you're going to see the patella either up or you're going to see the patella down. And so that leads you, along with your physical exam, to decide what kind of patella injury this patient has, right? What kind of, tendon injury has based on the patella's orientation, okay? So AP and lateral 30 degrees, there we go. There's the 30 degrees I told you about weeks ago, right? There it is, right? We don't want that double butt sign, right? We want the condyles overlapping. We want a perfect lateral, right? Which is denoted by the fact that the knee is flexed to 30 degrees. Can it be 20 degrees? Fine, right? 20 to 30 degrees, but 30 degrees is better, okay? And the condyles, right? The femoral condyles are overlapping, and therefore there's no rotation, right? Okay? Because how are we going to decide whether or not it's patella baja and alta for some patients where it may not be as clear cut? Okay? Because what does it say there? Do you need to get an MRI to decide which side's out? No, we should be able to decide based on radiographs, the orientation of the patella, okay, and based on exam. Okay? Do we get them? Absolutely. Well, whatever. All right. So there's a line that we draw here. Okay. So if you draw this line here, I won't tell you what this is, but there's a line we draw. Right? There's a little bit of a double butt there. Everybody sees both cheeks, right? All right. So, but this is 30 degrees. Decent. Okay. So when that line is drawn there, and I draw this line in my mind, right? But if you get out in phase 2, you'll see people drawing it for education purposes, right? But it's this line here at 30 degrees should intersect the distal third of the patella, right? When you draw the same line in this view here, does it intersect the distal third of the patella? No, therefore the patella is up. Entonces está alto, okay? It's up, all right? So in this view here, that line intersects the proximal third of the patella. So the patella is baja, está abajo, okay? Make sense? So that's why it's important when you guys say, I couldn't get the x-ray, tech said he couldn't get the x-rays, doc, his patient was having too much, where am I gonna send him? Back to x-ray, because I gotta get a radiograph to do this measurement, okay? This is just some insight, right? Will you potentially get a scenario that gives you this? Yes, but will you also get a physical exam finding? Absolutely, right? I believe in fairness, okay? But I'm just telling you, when you're out there in practice and someone says, hey, you gotta get better x-rays, right? This is what I'm talking about, make sense? But I don't want you to get upset, right? You need a hug to appreciate that there probably will not be good luck, by the way. All right. So, any questions about baja or alto? Okay. If you want me to just speak more Spanish to you later, let me know. Okay. It's $10 a minute. All right. But I'm just telling you, it's important to understand that sometimes if you just learn these root words and stuff, it just makes sense, right? So yeah, there you go. Permanent loss of knee extension, well, that makes sense. It's the extensor mechanism, right? Makes sense? Yeah. Yes, sir. More Spanish or?
No,
Okay.
or patients where you need them to be in a certain position. Can you just get some like?
I got a question for you. I think you were just about to say it. So when the ER calls me and tells me that the patient's in too much pain to do insert whatever, right? Do I respond with, I'm pretty sure you have more pain meds than they have pain? The answer is always yes. Okay? But what I mean, but let's take some stuff and put it together, right? Do you want to give them pain meds before you do a complete neurovascular exam? You do. Okay? So that's the rule. Make sense? But if you're going to send a radiology, and you have done and you're working ER, right? You're next year, right? Or very soon. And you're in the ER, right? And you're a student. And you say to the doc, I've done a complete neurovascular exam. I think it's this. I got all the radiographs. Patient is patella baja. I suspect. Okay, you're going to do that. You're going to give him a diagnosis, and you're going to give him a treatment plan. But I would like to send him for dedicated views. There were, I get the insult-Savali line. That's what that line is, by the way, that measurement. Okay, I will not ask you to draw it. But I think we should give him some narcotics so they can put him in the proper position of 30 degrees of flexion without any rotation. Therefore, when we call ortho, we're locked in, sir, for now. Okay? That's what you're going to do, sir. So that's what you were going to say. I heard it. I cut you off. I apologize. His moment of glory, and I stole it. All right. So let's talk about this. Those are big tendons, very strong attachment points, right? Okay? So do you think that you're going to have to do a lot of like strong suture material? All right? You're going to have to take both ends and put suture material if it's tendon to tendon, excuse me. so an intrasubstance tear. Or if it involves the bone, you see those dotted lines there? That means that we drill tunnels. Sometimes we use K-wires, right? Wires, and we actually run those wires through there and make these tunnels. And after we knot up the tendon, right? So that's what it's showing you there. Then we run those suture materials, or wire. We use wire sometimes through those tunnels, and then tie it into the patella itself. That's for a quad tendon. Does that make sense? Right? So what does that mean? That means that these have to be very robust surgical techniques, right? Because that's a lot of strength and a lot of force that's being pushed through there. Okay? So do you think when this patient wakes up, talk about this real quick. We talked about this. Do you think this patient is going to wake up in a range of motion brace with restricted motion so that it doesn't put the repair at risk? Yes. So when they come see you in clinic and they have a restriction, right? They're at 0 for the first 2 weeks, then they go to 0 to 30, 2 weeks in, et cetera, right? Make sure your patient's compliant, because if they pop that repair, right, is the second surgery ever as good as the first? It is not. Okay, so be careful with that. Okay. Sometimes that's what the knee immobilizer is, right? Although that's a little different, right? A knee immobilizer is basically the big sleeve with the 2 long bars, not the knee sleeve with the bars on the side. This is one long one, right? It goes from about here all the way down to sometimes the mid-calf or farther. It has 2 bars on the side, and it prevents absolute no bending, right? So you could go with that too. But the range of motion brace is better because like we talked about, then when you do want them to start flexing, they're already in that brace. Does that make sense? Right? But do you think a knee immobilizer might be good for a patella dislocation so they don't bend their knee again? So knee immobilizer are very commonly used for patella dislocations. We'll get there. What is a cylinder cast? Some would say that's outdated technology. Okay? But basically it's a circumferential cast that doesn't allow for flexion. So it sounds like a cylinder, right? Goes all the way around from about, again, here to about here. Okay, so it doesn't allow. We put that on the patient, and that's the way sometimes of us saying, we don't trust you. Okay, makes sense? But again, not very commonly done. Operative, do you think you want to get to it sooner or later? Do you want to get to it after it starts healing and it retracts? Sooner, within a week, okay? Re-tear within the first 6 months, I won't use ranks or names. Somebody, very high ranking. Had a quad tendon rupture, went to Hawaii. I said in Hawaii, came back to Misawa, fell in the parking lot, pop, goes the weasel. Okay, popped it again. Exam was back to where it was prior to surgery, more surgery. Okay, sucks, right? When you're flying on a plane, is that a risk for DVT? When you're flying back from certain major surgery on a plane, is that a even double whammy risk for DVT? What does that patient develop? Yeah, so DVT, right? All complete ruptures in a week, that's what you're going to send them, okay? We'll save this for tomorrow because I want to be fresh for this one, okay? All right, good luck with whatever's about to happen. Okay? All right, have a good day.